Okay, good afternoon, everyone, and welcome to QI Talk Time today with Peter Lachman, ISQA CEO, who's going to speak to us on leading for quality. We have 35 people online, and it's quickly climbing up, which is great. Great to have you all on board. If you could let me know in the chat box function if it's just yourself or if there's a number of you in the room, that would be great, just to get an idea how many people in totality are online. So Peter Lachman is the ISQA Chief Executive Officer. He has great experience as a clinician and leader in quality improvement and patient safety. Peter, if you wanted to move on the slide, that would be great. Dr. Lachman was a Health Foundation QI Fellow at the IHI and developed the QI program at Great Ormond Street, where he was the Deputy Medical Officer and also the lead for patient safety. Peter also is a consultant paediatrician at the Royal Free Hospital in London and specialises in the challenge of long-term conditions in children. He's the lead for SAFE, a Health Foundation funded programme which aims to improve situational awareness in clinical teams, and in Ireland he's the lead faculty in RCPI, where he co-directs the leadership and quality programme to develop clinical leaders in QI. He is the co-founder and chairperson of PIPSQC and the Paediatric International Patient Safety and Quality Community. So thank you so much, Peter, for joining us today. It's great to have you. Just really quickly, one or two housekeeping on the next slide. So throughout the WebEx, we will have time to look at comments and questions at the end. So if you have any questions for Peter or anything that you would like to ask him, pop that into the chat box at the end. That would be really helpful. Also, we have Twitter at QI Talk Time. Follow us. The hashtag for today is Leading for Quality if you want to make any tweets. For the sound, you can listen to your computer, but I've also popped in the phone number and the login details into the chat box function for anybody who's got problems. So I'm just going to hand over to Peter now, who'll take over from here. Thanks, Peter.
Okay, thanks, Roisin, and thanks for having me. Today we're going to talk about leading in quality, and this is going to be over the next 45 minutes or so, and then we will have time for some questions, and I hope it raises some queries and ideas, and we can take it forward. Firstly, just to let us know about ISQA, the International Society for Quality in Healthcare, which I'm the CEO. We recently had our conference in London, and many of you came there possibly. The next one's in Kuala Lumpur and followed by Cape Town. We are a membership organization, and that means that we work with members. We have a number of members, and we have two people from Ireland on our board. So I think it's very important that you join up, and hopefully you'll be interested in it after this talk. One of our big areas where we work is in external evaluation, and as you can see, we have a global presence in 34 countries going up, over 60 organizations, and we provide the standards, which they all develop with us, that most accrediting bodies adhere to. So that makes sure that there are standards to which healthcare can aspire. We have a great education program. There's a fellowship, specialist certificates, and we're developing undergraduate and graduate courses. These are very cost-effective ways of tapping into international experts, and we have weekly webinars just like this. The difference is we have experts from around the world coming to talk to you, and it's possible to do that quite easily, so have a look at that. Now let's get on to today's talk. It's basically based on this article, which I wrote with Wendy Nicklin, who's our current president, and it's been published in Healthcare Management Forum. It is available, unfortunately, as one of those that you have to buy unless you subscribe to the journal, but you're going to hear all about it in this talk. What I'm going to do in this talk is really talking about how can one really lead for quality as opposed to be a leader. Within healthcare, we have many leaders, not many who leading for quality, knowing what they should do. And I think it's time that we start accepting that leadership is not something that just happens, and leading for quality requires a change in the way we deliver healthcare. My view is that there are leaders are not only the titular leaders, with titles like CEO or clinical director, etc., but also people on the ground, frontline staff, have every chance of being a leader. And if you look at microsystems, every member of the microsystem has a chance of being a leader. I have in this talk 8 areas that I'm going to cover to effectively lead for quality. So let's go to number 1, which is what is real effective healthcare leadership? I've been in healthcare quality game for the last 15 years or so as the main focus, but ever since I became a consultant or every time I entered medicine. Now, the problem we have in healthcare is that patients are paying the roulette of quality and safety. It depends when they come in to hospital as to whether they receive effective care. Depends which team is on, which consultant-led team is on, which doctor, nurse, or allied professional sees them. Efficient care is something that doesn't happen that often. We have many patients who have to wait a long time to get in, so timely care and good access is a lottery. It depends who you know, where you are. Often there's a postcode lottery on that. Equitable care is definitely not measured that well, and it's only coming to the fore now in these 6 domains of quality. Safe care is not too bad. We get it right about 85% of the time, but we harm 15% of patients. So you could have a difficult time getting safe care if you're in a high-risk group. Otherwise, you may not get it at all, or sometimes you make sure that you can get it. And the final one on person-centered care is something that we've struggled with all the time. So a good leader is trying to decrease this roulette table of where your chips are as a patient. What we want to make sure that everyone has equal chance to receive high-quality care. And high-quality care means that it happens all the time, not only some of the time. So let's go forward and see how this can happen. We really need to move from this idea of risk management and quality assurance, which are essential and which were the foundation of the early work on quality improvement or quality of healthcare. Usually, this is about defending against harm. It's about national reporting and learning systems, which are often set up as a first instance. It's about concentration on sentinel events and things that went wrong. And in Ireland, this has happened on a number of occasions. And usually every 2 to 3 years is a major sentinel event that gets a lot of press and a lot of attention and major interventions with long action plans and ideas to say that this will never happen again until the next one 3 or 4 years later. It also requires reporting and getting alerts and so on, a really defensive way of managing quality. Patient safety and quality improvement really started after the foundations of risk management and quality assurance. It's not one or the other. It's both that are needed. And in patient safety and quality improvement, we're looking more forward and we're trying to anticipate and identify harm. We're looking at things from the eyes of the patient. We want system-level improvements and innovation and a change in culture. And that is what a leader is really doing, ensuring everyone has good risk management and quality assurance, but also moving to the areas of patient safety and quality improvement. Now, Holnar became quite interested in quality. Now, he's been around a long time. He's done a lot of work on resilience engineering in other industries, and he states that safety, and I added quality, is the ability of a system to sustain required operations under both expected and unexpected conditions. What he's talking about is something like air traffic control. Air traffic control has to be safe when it's busy and when it's not busy. It has to maintain the same standards at all times. Why could this not happen in healthcare? However, if you go to an emergency room, it's always safer when they're not busy, or is that so? When one's busy, are we able to do all the things that we're supposed to do? So this is something that we really need to look at. How can we maintain safety under all conditions, at all times of the day, no matter when? So it does not matter what time you go into a hospital or into a healthcare facility, it is always safe and you always have high quality care. Now, the theoretical approach to this is that we need to look at the culture, which is made up of individuals and systems. We need to look at individual processes, some things such as the human factors, which is quite popular, or we need to look at the systems, and that is the complex adaptive systems as healthcare has become more complex, more difficult to do, and patients themselves have become more complex. They don't have uni-organ disease anymore. So this all comes together. Now, these three approaches have provided the foundation for patient safety work, and effective leaders will take into account each of these areas and not only one or the other. So often I get worried when someone focuses only on human factors, but human factors are wider, or only focus on system change and not on the individual, because individuals make up systems. So we need to look at these three approaches and see what we're going to do. And we need to ask this question, are we generative? That means it's safety and quality, how we deliver healthcare. Are safety and quality the foundation of everything that we do? Now, I don't know of many healthcare organizations that can really say safety is our business, that we're constantly planning for safety, that we're constantly working on it. Too often, we are in a reactive mode, overwhelmed by patients, volume, and time constraints, always complaining about lack of staff, lack of equipment. And the question is, can we really make safety our business and ensure that we have high-quality healthcare? This leads on to something that is in the current domain right now of what's required, and this is the question of asking, do we have the habits of safety and quality? Are safety and quality within our genome? And I like this paper from Bill Lucas at the Health Foundation on what is required for the habits of a quality leader, a quality improver. And I've adapted again, saying this is really applied to safety. Are we in learning organizations? Are we individually learning? Do we use creativity to solve problems, or do we only follow protocols rigidly without asking how we can continually improve? Do we have resilience so that we can learn from things that go wrong in real time rather than in past time? And do we make connections to the system? But I think that we need to look at this, and I recommend you go into this, to the website to get this down and say, am I an improver? And have I developed the habits? Now, mostly what I'm trying to get here is that in order to be a generative organization, clinicians and frontline staff need to have the habits of safety and the habits of quality improvement. They shouldn't be thinking about it. It should be something that they just do. So let's move on to the critical factors for leaders in healthcare. Now, healthcare leaders have a difficult time. The rising demand, increased complexity, decreased money. So what do we have to do to think for the change? Over the last few years, I've been thinking about what are the real issues that impact on us as a leader to get change to happen. The first thing is power differentials. We've built healthcare on a very hierarchical basis, and a lot of the power remains in the medical profession. Even in multidisciplinary teams, this happens. Hierarchy is one of the benefits of healthcare, or one of the good things, but also one of the negative things. You need to have hierarchy, but it needs to know when to flatten and when to be rigid and when to be flexible. Many of us work in very traditional type of organizations. We've always done it this way. This is the way we do it in this hospital, therefore we can't adopt national guidelines. We often work in silos, which is one of the biggest dangers in healthcare. And we tolerate dysfunction, teams that don't work. We don't concentrate on teamwork. We make sure that we protect each other if things go wrong, even if it's dysfunctional. And finally, the professionalism of healthcare. We need a new professionalism, a new way of thinking what the roles of doctor is, what the role of a nurse is, how we interact with each other. And all of these factors, power, hierarchy, traditions, and silos, all of these interact together, and we need to really address them head on. We're often not very good at doing that and making sure that we address each of these issues. To achieve this, we will require new ways of thinking. I like the thoughts or the teachings of Deming. They appear in many of the interventions that you may think of. So, for example, frontline ownership, that comes from one of Deming's 14 principles. Microsystems theory, that comes from Deming on how teams work. We need to change our culture. We need to change the way we speak and act and teach. And often might see when if we move into generative patient safety, how do people speak? What do they use? If we move into person-centered care, what's the discourse? How do people interact? And finally, we need to have active changes. We have to adopt new ways to solve challenges. We cannot continue as we are, and as leaders, we need to actively change. If you want to read more about this, you can look at the white paper from IHI, on which I based the slide. So to really get change, we have to understand systems and the people within the systems. And systems thinking, which comes from, this is the profound knowledge from Deming, really means we have to understand where we work and how our system interacts with other systems. Variation and the study of variation is something a leader has to constantly do, and one has to understand why people think in a certain way and why they ensure that there is a variation when there shouldn't be. Why do we prescribe a certain antibiotic, for example, when everyone else does a different one? Why do we think that we have to manage things in one way and not in the other, not the way that is recommended? And finally, one has to have a theory and method of change. And a lot of what we're doing in quality improvement work and in patient safety work is developing theories and methods of change which are applicable to healthcare. So, for example, care bundles have a theory and a method of implementation, and these all help to decrease harm. So systems theory is really good. We then have to have a plan and controls as well as management. Now, this comes from Duran, who worked alongside Deming at the same time as Deming, both being trained by Schubert. And Duran really said that you have to plan for quality, and I think this is essential. And this applies not only to the leadership, but to everyone, to clinical teams, microsystems. They have to plan for quality and safety. And quality and safety planning is the start of the journey. One then has to set up the controls, and that's the measurement systems. And we'd like you to have run charts or statistical control charts, safety crosses, but some kind of control so you know how you're doing and how you can go forward. And these need to filter up to the leadership and back down to the frontline staff. Quality needs to be managed. You need to have people constantly managing the plans that they have implemented, and you need to have a process to improve. Now, this trilogy, or now four-part way of improvement, is the foundation of any leadership for quality improvement. This needs to be on the desk of the CEO, of the clinical directors and nursing directors, as well as the clinical teams. At all levels in every organization, they should have some form of quality planning, control, management, and improvement. And it's an iterative process that continually goes on. One never, ever ends the process. One's continually improving more. Where ISPRA comes in here would be in the quality and safety control, setting the standards. So the planning, and then you have standards, and the management is to see whether you reach those standards, the improvements, to see whether you can exceed the standards. And once you've done that, the standards improve themselves. So this is a constant way going forward. For me, safety is a constant problem. I've adapted this from the Charles Vincent and Burnett and Carsey papers, which you can get from the Health Foundation, download for free. And I've added what to do well, learning from excellence. And I've been teaching this recently, saying that clinical teams, divisions, organizations should be asking at all different levels every day, what did we do well? We shouldn't be looking at harm as how did we harm in the last 3 months, the last 6 months, but rather on a daily basis. did we harm anyone in the last 12 hours? So, for example, on the Pressure Ulcer Collaborative, my advice to the teams there would be to ask on a daily basis, what did we do well in preventing pressure ulcers? How did we have anyone develop one in the last 12 hours, last 6 hours? You can apply that to anything, falls, medication harm, etc. The reliability is doing exactly what we're supposed to do. Do we follow the guidelines that we're supposed to follow? Do we give care as we've agreed to give care? Being sensitive to operations is knowing exactly what's happening in the front line, knowing whether you're safe right now, whether you're providing quality service today, not quality service over the last 6 months, last 3 months. It's too late then. And finally, anticipating whether you're going to be safe over the next 6 to 12 hours and learning from this process. I believe clinical teams can do this on a daily basis every 12 hours as part of their handover. They can do this as part of huddles. Leadership can do this every day too, getting the information from the clinical teams. So an organization then is saying, we are looking for problems. We are proactively trying to be safe, proactively trying to provide high quality care, and we're mitigating at all times. The third area of good effective leadership is person-centered care. Now, person-centered care has been quite popular recently, and I know there's been a campaign in Hello, My Name Is, and that's quite laudable. But the reason why it's not patient-centered care versus person-centered care is because person-centered care is about patients, and I think that's quite important, and you know that that's where our focus has been. It's also about providers. Providers need to be cared for as well, and this is an area where we haven't been that good. So person-centered care is about patients and providers. In order to provide patient-centered care, one needs to provide provider-centered care as well. An effective leader will really look after his or her staff, really ensure that they are cared for, that they have all they need to work, that they are supported when things go wrong. So, for example, medical error often causes a second victim. How do we help the second victim? There's a new focus on burnout in clinical staff. Up to 45% of clinical staff are burnt out at any one time. How do we manage that? An effective leader is constantly looking for this and ensuring that the staff are cared for at all times, not only when there are things that go wrong, but especially when there are things that go right, and also that they look for excellence. The second victim is really something that is now coming into the light now as we realize that stress-related work traumas is more common than we thought. IHI have recently produced a framework for improving joy at work. Now, joy in work is something that you might think is quite American. However, here you can see the things that they're really thinking about. With happy, productive workers, caregivers will have far better impact on person-centered care or patient-centered care. And this needs to be done on a daily basis. It's not done something like a yearly assessment of views of the staff, but rather on a daily basis, looking at psychological and physical well-being, measuring it in real time, feeding back, and constantly nurturing staff in order to ensure that there's person-centered care. Another document that you could download. So safety and quality must be viewed from both the eyes of the patient and the eyes of the provider. We as leaders need to walk in the shoes of both the patient and the frontline staff in order to ensure that we have high quality care. And to do that, we need to start listening to patient stories as well as to provider stories. This will bring the reality to work, and leaders need to do this. And that can happen at all levels. Too often, we do not talk about provider stories, and too often, we only hear patient stories when things go wrong, rather than patient stories when things go right. I think it's essential that we combine the two, and storytelling is so important to supplement the data and enhance it, and tell us how things are going. I like this quote from Atul Gawande: "Life is meaningful because it's a story, and the story gives us the idea of what's going on." And I think it's really important that we really know that stories are the foundation of human beings, and we constantly need to take stories, and too often we don't listen to the stories of those in the front line and the stories of the patients. So leaders need to listen more. So person-centered care, in summary, is what happens to caregivers and patients. And Alf Collins really put this for patients, but I really think this applies both for patients and for staff, of personalizing the care and making it safe, even though it's standardized, of coordinating care, and too often care is not coordinated. It's frustrating both for caregivers and healthcare providers and for patients. Enabling safe care is something that one has to do, and that's part of the management. We have to enable frontline staff to provide safe care and enabling patients to participate in their care. And of course, dignity and compassion applies to forgiveness to patients and also how we treat each other. How do we work together and treat each other with dignity and compassion to ensure we can do likewise for the patients that we serve? The fourth area is this idea of reliable care. Too often, we do not give the care that we're supposed to do, and this applies both to the system and the individual. Now, one of the reasons we don't give reliable care is this problem of culture, is that we allow things to happen, and the worst behaviors are often what we tolerate. We often tolerate unreliable care. And why do we accept this in our inability to deliver the right care at the right time every time? We often say that this is due to lack of resources. Now, that may be true in some of the cases, but we really need to try and look at where we have things under our control that can make a difference. And now, for myself as a doctor, these are the things that are under my control that I can try to make a difference. I could look at ways of improving prescribing. It's really quite shocking that in this day and age, we have problems with prescribing of medications, that they're still wrong, even with electronic prescribing, which is not the answer. This is a cultural issue, and there are many ways we can improve prescribing and ensure that prescribing errors do not occur. The WHO has an initiative this year on medication safety, and prescribing is going to be one of the big areas. Why we overprescribe antibiotics and prescribe wrong doses, etc. Hand hygiene is a very personal thing, and we can make it very easy for ourselves to personally take that on board. Poor medical records is the bane of healthcare. That is something that every doctor or every clinician who writes in notes can take responsibility for and improve. One doesn't need anyone else. An area that is rather concerning nowadays is incomplete handover. And there are tools that we can use to improve handover, and we can make it something more standardized and much safer and of higher quality. The final one of not following agreed protocols is that the protocols need to be followed all about. Now, all of this is shared. This is the responsibility of clinicians, the responsibility of all those involved in healthcare, but some of them are more personal than others. Now, a query we could have is asking whether our care is reliable. And I refer you to this new book by Charles Vincent and Renee Almaberti, which you can download for free, again, funded by the Health Foundation, so I recommend that you look at it. And this is an extension of Almaberti's previous work on ultra-safe care. And what they are saying is most of us live in this illegal normal space in which care is not 100% reliable all the time. Sometimes care tips down to where care undermines any benefits, and sometimes it's up in optimal care. For example, optimal adherence to standards, blood transfusion would be up there, radiotherapy often is up there, anesthetics is moving towards there. But most of us work in this unreliable area. So I think that we really need to look at this and see how we can get that all together. Because really reliable care means that we get all of these into place. that we coordinated and safe. We have, if you're in a hospital, patients in the right bed with the right nurse for the right condition and the right treatment. And the treatment is the treatment that is recommended and agreed upon beforehand. So reliability is something that we really need to look at, and it's very difficult to do because we tolerate things that are not reliable. So really, a message to all of us is that we can try to improve safety with something, each individually, that we can do. And what the leader has to do is facilitate it, help it. So, for example, for handover, implement standardized handover systems such as iPass. For medical records, ensure that medical records are able to be of a high standard. Hand hygiene to facilitate that, so etc. So we really could apply this and really work on it, but it does require individual responsibility as well as system intervention. I'm not going to spend too much time on the next area, change in education. I'll be speaking about it next week at the college, at the RCPI. But we cannot continue educating as we currently do. The objectives of a quality healthcare education means that the next generation of doctors and nurses and allied professionals should not receive remedial work as they currently have to do. They should not be searching for knowledge on quality improvements and patient safety and human factors, etc. It should be part of their day-to-day work. And the only way that can be is if medical schools and training colleges change their curriculum, if our postgraduate medical education includes quality and safety as core parts of equal value to the other subjects that people have to learn. So I'll be doing more about this next week, but I'm saying that the underlying thing is that leaders ensure that their future staff and their current staff will have the tools they can do, that they need to improve quality and safety. Now, the business case for quality, this is number 6, is the next step that has to take place. We have been a bit remiss in this area, and we haven't started from the start, making the case that it is far better to have high quality and high safety than not to, from a financial point of view. Now, this is a truism, but we need evidence, and I'm pleased to see that the economics of patient safety is now becoming central, and Nick Lazinka was recently in Dublin at the Patient Safety Conference talking on this, and I think this is very important. You can download this because this gives you some of the evidence of patient safety, why it is better to estimate to be safe and not to be safe. What they do is they look at the cost of failure. So, for example, what is the cost of a line infection? What is the cost of delays? What's the cost of a trolley wait? And you can really work out that cost. And then you can look at how you can reduce harm by looking at values. You can look at the cost of the intervention, and then you could work out how the cost of the intervention decreases the cost of the failure. And basically their message is preventability cost is less than the cost of the harm and adverse events. Now in Ireland, we've been doing this for some time at the Diploma on Quality Improvement and Leadership that's run by the college and HSE. We have been asking teams to quantify the cost of their intervention and how much they have saved by intervening. And really, the cost has been decreased dramatically by many of the projects. However, we're not doing this forward. Rasheen, can you hear me, please? Because I see I've got a sign.
It's fine, Peter. Yeah, absolutely fine. Thanks.
Okay. Okay, fine. So basically the message is, this is the message, that leaders who have leading effectively for quality and safety look at the cost from the start. And that's something that we need to do. We often do it as an afterthought, and we need to build it in. Because if we can save, then we can really make a difference. And we can spend that money we have saved elsewhere in the system. One of the ways you can do that is by this program, which is Choosing Wisely, and I've been working with them recently. I'll just go back to that. choosing.
Is there a problem with the slides, Peter?
Yeah, there's a problem with the slides. Can you get me back on? Because it's my slides.
Yeah, they're sharing from your computer, so I don't know why it's doing that.
Just hang on a sec. Okay, I'm just trying to get the arrow, find out where my arrow's gone. Can you get?
If you hover up at the top of the screen, Peter, you should be able to click on. Hover up at the top of the screen. Yeah.
Yeah, I can get that. I can't see the arrow. Are we just working on it? Zoom slideshow, but I want to.
But you can't see the cursor at all.
No.
Oh, hang on.
If you hover up at the top toolbar, you should be able to click on.
I should accept it.
There's something happening over here.
On the internet connection, is it? Apologies to everybody online.
Okay, we've got it again. Okay.
Okay.
So sorry about that. So choosing wisely is a system that has now been spread around the world, and we at ISQA are working with them to see how we can really choose the right treatment. And this is really working with clinicians at deciding what the right treatment is and helping patients and clinicians choose the right treatment. The next area, second last one, is on network learning. And network learning is about how we can learn together. And actually right now you're on a network, and this is an example of network learning. And what we really need to do here in Ireland is develop this network of improvers and leaders interested in quality improvement. The Health Foundation has published a number of papers on networks, and this is one of them which shows you what the real role of networking is and how important it is to get this going. So what we are trying to do now is facilitate learning and amplifying the messages so that improvement can spread more widely. At ISQA, we are a big network, and we have networks around the world, and we hope that we can facilitate quality improvement in leaders worldwide. Now, the last one area which I'm going to do before questions are saying, with all these 7 things that we have to do, from business case for quality, from understanding patient safety and planning for quality and safety, to educating for safety, what do you really need? And these are the 7 or 8 things that I think a leader needs. You need skills. You need skills and you need vision. The skills and vision, the vision is something that leaders don't often have, the vision to be better. The skills is often that we don't have. Many leaders don't have training in quality improvement and patient safety, so I think that's essential. The vision must lead to hope, and the hope of things getting better. That will require respect for what's going on, and respect for the people in the system who are really working hard, and respect for each other, respect for the patients. And that goes back to the person-centered care. Leadership must be distributed and must be right down to the front line so everyone feels they can lead at different times. But more importantly, leaders need to have courage. They need to be willing to take the risk to improve and to do things differently. And finally, they need to provide the time and space, which is something that we always claim we don't have. I have no time to improve. We need to create that time, even though it may be very little. So these are the key attributes of the leader, and I think this is something that we need to really face in the future. I really like this quote from William Foster, that quality and safety is not an accident, and quality and safety is something that you have to plan for. It's a decision, it's a wise choice, and like choosing wisely, you have many choices in life, but you can choose to be safe, you can choose that as a leader, you can choose that as a caregiver. You do choose to provide high quality care, and we need to make that choice easier to do. Now, the effective leader is constantly making sure that those around him or her are able to provide good quality care and continually try to improve. Thanks very much. Roisin, you there?
Thanks a million, Peter, for an excellent, very informative talk. We have had quite a number of questions actually coming up, and there seems to be a little bit of problem with connection on the slides there, but not to worry, we have some time here for some questions now. So Rose McCall actually has asked, thanks for your question, Rose, patient care is not just the responsibility of a clinician or carer. The provider of safe care must nurture individuals and teams to share the load. How does the provider ensure the caregiver is supported by the organisation?
So could you just repeat that for me?
Yeah, so I'll just go into it again. So patient care is not just the responsibility of a clinician or caregiver. The provider of safe care must nurture individuals and teams to share the load. How does the provider ensure the caregiver is supported by the organisation?
I'm not quite sure where I get that. How do you mean the provider? The leader, is that what you mean?
Yeah, I suppose she's probably talking about, the CEO, the top level management of the organisation. How do they support their staff on the ground?
Well, I think in the first case, it starts with a simple recalibration of what the purpose of healthcare is. To me, many managers or many clinicians do not put safety and quality as their number one raison d'etre for being in the position. It's more about the bottom line or meeting targets, and what we really need to look at is how safety and quality become the actual work of healthcare rather than healthcare being the work of healthcare. If you go to a hospital, it's very unsafe, and our job is to keep people safe in hospital and then provide healthcare. So we should be really looking at it. So the question is quite complex, because my first thing is that at the top, you have to develop the culture. The culture works bottom up and top down. And so in healthcare, the leadership needs to start looking at how quality and safety becomes their raison d'etre, their business strategy, quality and safety, rather than providing healthcare. And while they're providing that, then their healthcare, because healthcare is what we do, quality and safety is what must cover it all. And I think that's very important, the change of culture first.
Okay, great. Thanks, Peter. We've quite a few actually comments and questions coming in. And just one moment there, I'm just coming to the next one. We actually have somebody from Delhi online, so that's great. Thanks for joining in. So we have a question here from Anchor Sudan. Should we invest in developing leadership capacity at national and provincial level first, or focus on health facility level improvement initially?
I think it's not one or the other. It says that we're doing remedial work a lot of the time. So I think that in order for clinical teams to be effective, they need to be supported by, I'll say, enabled leadership. Leadership that understands quality and safety, that knows impacts of decisions, that understands the way their decisions impact on the frontline staff. So I would go national, looking at training national leadership, but not on leadership, but on quality and safety leadership, not only leadership as normally taught, and also training clinical teams at the same time. So it's a massive approach in changing the way we go.
Yeah, and actually Karen Reynolds, thanks Karen for your question. She's on a similar thread in supporting implementation of quality and safety. If you could recommend one change for the Irish healthcare system, what would it be? In a nutshell, Peter, what do you think?
That one's quite difficult, because one change usually leads to another change. But I would say that it's moving from the reaction and counting a lot to a conceptual change that we should look at an Irish solution. We get a lot of things coming in from outside and saying this is how we do it here, I would concentrate on the big solutions, enabling clinical teams to improve. But this will require culture change, moving from blame, which is quite pervasive here. And I think we really need to educate the press on what we're doing, and so that they get good stories, because actually most of the time we do get it right. If you think that over 80% of the time we are getting it right, so we want to improve that continually. So we need to get the good stories out, we need to build on excellence, and we need to share. And we need to really network. So I would say building this network of improvements and network of leaders who really want to improve, I think is the first step.
Great. Danielle Bracken from James Connolly Memorial has asked, talking about the idea of person-centred care and how, you know, the concept of it being about both staff and patients. And she likes the idea of all of us making improvements that are achievable and important to us as individuals. Her question is, how do we consistently get the message to staff that they have the permission to make changes and a change can start with them?
Well, that again is on the culture of the organizations, because I've worked in different organizations where that works and it doesn't work. I really think that there's this balance. What you want people to do is know what the standards are and allow people to try to get to those standards. You want to standardize care, that's one of the things, but you also want to enable people to take ownership of the improvements. Your next talk is about frontline ownership, so maybe that's where we should go, is how do you allow the frontline to, the front line to own the problem, and Rob will be dealing with that next time.
Yeah, great. So tune in the next time. That was a nice advertisement for the next one, Peter. We have another question here. As measurement and monitoring of safety is an essential part, should we have recommended tools accessible to HSC managers to achieve the same?
The tools. I think one of the key things we need to do in a country the size of Ireland is to have to agree on an approach that we're going to follow, and to try and make tools available to people that they can use. And I think in patient safety there are many tools that one can use, and standardize a lot of things. It's just the right size country to get massive gains. And a lot of the research where it's been really good is in countries the size of this, like Denmark, Scotland, all about 4.5, 5 million people, right number of hospitals, right number of clinicians, whether doctors, nurses, or allied professionals, and just the right attempt to get this into action. But we need to unify a lot and stop looking at so many different solutions.
The next question actually follows on nicely from Sonali, and she's asking about looking for a single point high impact intervention, for example, beta blockers in heart failure. She's looking for something to work on, to design a collaborative around. Is there any resource I can find which lists these possible quick wins across all/any specialities?
So the key of the question is how do we get it across different specialities?
No, I suppose what she's looking for is there anywhere that you can find, you know, I suppose it's the spread of ideas of things that have worked well. So is there a resource that you can find which lists possible quick wins for improvement across specialities? I suppose, you know, like the interventions through the safety programs, things like that.
Yes, I think that there are examples that you can get in different areas. So if you look at the Scottish Patient Safety Program, they've got good examples going across specialties. But really, really the principles are quite there. It doesn't really matter which specialty you're on. The specialties, the work that one requires in order to improve has basic principles. And if one sticks to the principles and applies them, then you can get improvement across specialties. You just change the subject matter because the actual intervention is the same.
Yeah. I can actually put some stuff alongside this talk and might direct people a few links. So we'll do that afterwards. If you visit the QI Talk Time webpage, we can direct you on to some links, so that we'll have that in the next few days up there for you. There's one other interesting question from Sonali, and he's asking, if you were the first person leading or pioneering QI in the US and had to choose between one, institutional-wide quality improvement, for example, at Hopkins or Harvard or Baylor, or two, a large-scale collaborative campaign focused on improving a specific area of care. So one of them is about investing in your leadership, or the other one would be investing in a clinical area and investing in the team around that. It's probably a combination of both, isn't it?
Yeah, Stacey, I think that you should have both national campaigns focused on individual conditions. I think that's very important, like we've had with pressure ulcers, and there should be a whole series of them. And then when I was in the UK, I used to run something called Leadership in Patient Safety, which we took any condition, and we used to run them through the NHS Institute and have up to 30 teams at a time learning from each other, but with different conditions, and the learning was immense. So I think you have to be pretty flexible, but what's quite clear is you need to have one theory and one change. So I'd really recommend that the theories should be focusing on, say, something like microsystem theory, which encompasses all, but that we should try to stick to the same thing, because that includes the methodologies of quality, of model for improvement, et cetera, and we should try to have one type of approach. So we say this is how we do it in Ireland, because this is a small country. And in a small country, we shouldn't have so many different ways of doing things. We should allow different hospitals to experiment in other areas, but nationally, we should have one policy.
Yeah, no, absolutely. And there's a lot of really good, excellent improvement work going on out there. And it's about joining that up and connecting people who are involved in quality improvement. And I suppose QI Talk Time is one possible way of doing that. There are no other questions, Peter. Unless you have anything else to add, I might wrap up, and thank you very much for your excellent, insightful presentation. Lots of comments coming in there. Thanking you for your time.
Yeah, thanks. And if people want the article, they can always write to me.
Yeah, perfect. So I'll just wrap up now. Thank you very much again, Peter, for your time. Also, just to let you know, there are some very good, helpful links there on qualityimprovement.ie. So if you go on there, you'll see some helpful information, tools, etc., on the framework for improving quality, and also on the Improvement Knowledge and Skills Guide, and the link for that is below. So the next talk that we have coming up is, as Peter alluded to, is with Dr. Rob Honey and Monisha Gaidara, who is our staff engagement lead. And that talk is on frontline ownership techniques, and it's on the 5th of December, again at the same time. So if you want any further information, please don't hesitate to contact me, roisin.breen@hsc.ie, or follow us on Twitter at QI Talk Time. And thank you very much again for joining in to our presentation today. Thanks very much. Bye.
Thanks, bye.
Bye.
Roisin,
yeah?
Could you see the last slide? Could you see the last slide or not?
Yeah, I just put it up on mine, Peter. Something happened there, so I don't know. It came up on mine. The connection went a bit funny, actually.
Okay, thanks. There was something here with the IT.
Yeah,
okay.
but it was absolutely fine, because I just pulled it up on mine and showed it on mine, and everyone said that they could see it then. So it was just the last three slides of yours. So it was just
Roisin, Simon here as well, Peter. So the connection really, it dropped towards the end of Peter's presentation, did it?
Yeah. I don't know what happened there. The last two slides from Peter's slides, it just stalled a little bit. But I must say, lots of really good comments coming in, actually. There was 65 people online at one point, Peter, which is great.
Okay, that's great.
Yeah, so I have that recorded, and yeah, so I